So we'll just wait 1 minute so that everyone can attend the meeting and log in properly.
Okay.
Okay, so I think we can start. Good afternoon, everybody. I'm very happy to welcome you all to the webinar on MMA embolization for chronic subdural hematoma. I'm Meningeal. I'm a hybrid neurosurgeon from Radboud University in Nijmegen, the Netherlands. And it's a great pleasure to introduce to you today Jiri Bartek from Karolinska University Hospital in Sweden and Laurent Pierrot from Reims Hospital in France. And they will both inform you first. Laurent Pierrot will tell us about the STEM and Optimize trial and the results from those, and Jiri will inform us about the consensus meeting. Laurent, can you please start by sharing your slides? And before we start, I would like everyone to ask the questions in the Q&A section of Zoom and not in the chat function, because then it will be easier for a moderator to follow the questions.
So thank you very much for inviting me to present regarding embolization of chronic subdural hematoma. I am Laurent Pierrot. I am a professor of radiology in France, and I was a STEM co-investigator. So here are my disclosures. So very rapidly, but I think you know, all of you knows what is MMA embolization. You know, there is an increasing interest for MMA embolization in the treatment of chronic subdural hematoma. You see here the number of paper and the number of citation in the last 10 years. And you see that the number of paper is increasing as well as the number of citations. So the background, you know it. We imagine that there are some inflammatory cells within the membrane, and that these inflammatory cells are responsible for a pro-angiogenic role, which is a support for the development of new vessels in the subdural region, creating a microhemorrhage and fluid exudate. So by doing embolization, we expect that we will reduce the risk of bleeding, rebleeding in the chronic subdural hematoma. So just a short example, subdural hematoma in a male 62 years old. You see here the management, the embolization with SQUID 18. So we embolize both branches of MMA, and you see the results 3 months later. Here another example, male 65 years old. It is 2 days after burr drainage, and you see that there is a large reduction in size of the subdural hematoma. 2 months later, we have a rebleeding. There is a new a second surgery with the drainage now. And you see, we were doing 1 month after the second surgery, we were doing MMA embolization with SQUID 18. And you see 1 month after MMA embolization and 6 months after, we don't have a recurrence of the subdural hematoma. And now you see that the situation is stable at least at 6 months. So the multidisciplinary consensus will be presented by Jerry, so I am not presenting. So I will just discuss RCTs. There were 4 RCTs, STEM, EMBOLISE, MAGIC MT, and PROTECT, and I will present STEM and EMBOLISE. So STEM was conducted by Dave Fiorella and Adam Arthur in US. It's an international study. There were most of the sites were in the US, and there were some sites in Europe. It's a randomized controlled trial, which is comparing standard management with or without surgery versus standard management plus adjunctive middle meningeal artery embolization with SCREED. So you see that the number of patients was 310, And so the first decision was from the neurosurgeon who was deciding if there is an indication for surgery or not. There was a surgical management arm, and when in this arm there was a randomization with and without MMA embolization. Same in case there was a decision not to operate the subdural hematoma. In that case, there was again randomization with and without MMA embolization. So the key inclusion criteria were age greater than 30, premorbid MRS 0 to 1. The chronic subdural hematoma has to be greater than 10 millimeter in its greatest thickness, and it has to exert mass effect upon the subjacent brain. So it has to be a chronic subdural hematoma, and the patient has to have clear neurological symptoms. So symptoms were headache, cognitive decline, speech difficulty, gait impairment, blah, 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 blah. So all you know it. So the primary endpoint of STEM was failure at 6 months. So you have 3 failure which were possible: residual or reaccumulation of the subdural hematoma greater or equal to 10 millimeter at 6 months. You have to have reoperation after the initial intervention or a surgical rescue in the non-surgical arm, again at 6 months, and any new major disabling stroke, MI, or death from neurological cause at 6 months. The primary safety endpoint was major disabling stroke or any death within 30 days from intervention. So here, nothing really special regarding demographics. You see mean age is similar in all groups. There is a greater percentage of male. You see that the symptomatology was mostly headache, gait impairment, or focal neurological deficit. There were a lot of patients treated with anticoagulation or antiplatelet use, which means close from 40%. So when we look at the primary effectiveness endpoint in STEM, you see that the percentage of failure is, in case of standard management without MMA embolization, is 36% compared to close from 16% in the arm with MMA embolization. So it makes both patients treated with surgery or without surgery. And the difference is with an odds ratio of 0.32, with a p-value which is 0.302, and you see that it's significant. So it means that there are more failure when without MMA embolization than with MMA embolization. Now, when we look in the different arm, which with and without surgery, with surgery, the rate of failure was 23.4% of cases compared to 39.9% of cases if you add MMA embolization. In case the patient was not treated with surgery, in non-surgical management without MMA embolization, the rate of failure, which means more or less recurrence or retreatment, was 55.8% compared to 18.8% in the group with MMA embolization. So in the surgical arm, the odds ratio is 0.53 with a p-value of 0.14. So it's not significant. It's close from significant, but it's not. And in the non-surgical arm, you see that it's highly significant. So when we look now at the MRS outcome, there is no difference between both groups with and without MMA embolization. Here it is a rate of MRS 0 to 2 in the both groups. Now, when we look at what happens regarding the rates, the rate of bad clinical outcome, which means more than MRS greater than 2, sorry, you see that the rate of failure, the rate of MRS greater than 2 is higher in case of failure, which means 60.3% of cases compared to 7% when you have the primary endpoint is not reached. So the failure mode is the most important, is maybe very important, is most of the failure mode was reoperation or surgical rescue. And this reoperation on surgical rescue was mostly based on imaging and clinical deterioration. Now, when we compare the safety outcomes, all-cause deaths, we have a similar percentage in both groups. And there was no death in the treatment arm related to MMA embolization. And there was no difference also regarding major disabling stroke in both groups. So the conclusion of STEM is that adjunctive MMA with SQUID reduce the failure rate for the standard management of chronic subdural hematoma with a number of patients needed to treat is 4.7. Also, in fact, the study was not powered to demonstrate a treatment effect in each subgroup with and without surgery. What we can see, it reduced the failure rate for the non-surgical group with a number needed to treat of 2.6. It's not the case. There is only a trend toward reducing the failure rate for the surgical management of chronic subdural hematoma with an NNT, which is higher. So adjunctive MMA embolization with SQUID does not result in added morbidity or mortality when applied as an adjunct to standard management. Adjunctive MMA embolization in STEM does not improve overall functional outcome in patients with chronic subdural hematoma and does not reduce rates of mortality in patients with chronic subdural hematoma, probably because disability and mortality in this population is frequently related to medical comorbidities. However, for patients with treatment failure, which means that there was recurrence or reintervention, there is a strong trend toward greater rates of death and disability compared to patients with no treatment failure. So now EMBOLISE. EMBOLISE, there were two arms, one surgery cohort and one without surgery, but we just have the results of the surgery cohort as of now. It was published in New England, like STEM, by the way. The goal was to evaluate safety and efficacy of the MMA embolization. It's a multi-center prospective randomized controlled trial in US. The goal was to have up to 60 centers across the US. The goal was to include 600 patients overall, 400 in the surgery cohort and 200 in the observation cohorts. So there are two separately powered cohorts, which is important. So it was powered for the surgery cohort and the observational cohorts. So here I am just presenting, because it's only results we have for the time being, surgery cohort. The randomization was 1:1, Onyx MMA embolization plus surgery or surgery alone. So I will not discuss too much key inclusion criteria. Age was 18 to 90. Premorbid modified Franklin score has to be 0 to 3. And indeed, we have to have a diagnosis of subacute chronic subdural hematoma by brain imaging. Treating neurosurgeon has to have the intention to treat surgically the subdural hematoma. And there were indeed some exclusion criteria, including one which is a life expectancy less than 1 year. So the primary endpoint was the rate of hematoma recurrence progression recurring surgical drainage at 90 days post-treatment. So it's not exactly the same timelines as STEM. There was also a non-inferiority assessment of onyx embolization treatment deterioration defined as for MRS inferior to 3 at baseline, MRS greater than 3 at 90 days, or for MRS greater or equal to 3, an increase of at least 1 point on the MRS scale. There were other safety and secondary effectiveness endpoints. So 400 patients were enrolled and randomized across 39 sites from December 2020 to August 2023. You see here the randomization at the end in the onyx MMA embolization plus surgery. You had 167 patients at 90 days. And in the group of you had less patient in the, a little bit less patient in the other group. So here you have the population. Again, nothing special. When you look at the symptomatology presented by the patient, it was more or less the same as in STEM, you know, headache, gait instability, limb weakness, cognitive impairment, focal neurological deficit. The modified quantity scale was not different in both arms before the treatment. The rate of antiplatelet or anticoagulation was a little bit less compared to STEM, around 17%. So surgery was done by burr hole in half the cases, more or less, in both groups, and by craniotomy in both groups also. And now when we look at embolization, you see that successful embolization was performed in all cases. There was a reflux of in a limited number of cases, which means 1.1%. And what is important probably is the distribution of onyx was proximal and in more or less 50% of cases, and distal, because it's a discussion, technical discussion, should we have a distal or proximal embolization? So the PIs of Optimize will probably do an analysis of the results depending on the proximal and distal distribution of onyx. So when we look at the results, the primary endpoint, which is subdural hematoma recurrence progression requiring surgical drainage at 90 days, you see that it's the rate is 4.1 is onyx embolization group compared to 11.3% in the group only treated by surgery. So there is a statistically significant threefold reduction in recurrence after MMA embolization with onyx. Now, when we look at the test for deterioration in neurological function, you see that we have a deterioration in 11.9% in the MMA embolization group compared to 9.8% in the surgery alone group, and it is not significant. So deterioration in neurological function was non-inferior in the onyx group versus the control group intubation with subacute and chronic subdural hematoma. Regarding the safety endpoint, you see that there was no complication regarding to onyx. There were severe serious adverse event in 16.2% in the MMA embolization group compared to 21.7% in the surgery-only group. So there is a low rate of subarachnoid serious adverse events related to onyx MMA embolization within 30 days, and there are no adverse events related to onyx embolization. So when we look at neurological deaths, there are 4.6 deaths in the MMA embolization group compared to 2.5 in the surgery alone group. there were no neurological deaths related to onyx embolization at 3 months, and there were no neurological deaths related to MMA embolization at 3 months again. So in summary, EMBOLISE study shows that MMA embolization with onyx led to a threefold reduction in recurrences requiring surgery compared to surgery alone group. Clinical deterioration, the clinical deterioration is non-inferior in the MMA embolization group compared to surgery alone group. And in terms of safety, there was no adverse event related to the onyx device. There was a low rate of serious adverse event related to MMA embolization within 30 days. And there was no difference in rates of stroke or neurological deaths at 3 months. There were no neurological deaths or serious intracranial hemorrhage related to the onyx device or the MMA embolization. So the conclusion of OPTIMIZE is that adjunctive MMA embolization with onyx was associated with significantly reduced rates of reoperation without compromising neurological function or safety. So MMA embolization from the investigators of OPTIMIZE should be considered for patients presenting with symptomatic subacute chronic subdural hematoma requiring surgery. Thank you. So I will not, I will skip that. Thank you for your attention. And I think we will have the question at the end of the presentation of Jiri. Thank you.
Excellent. Thank you, Laurent, for this beautiful overview. As Laurent already said, I would like to invite everyone to post their questions in the Q&A section, and then we can answer them after the second presentation from Jiri. Jiri, can you please share your slides? Jiri?
Yeah, don't worry, I'm here. I'm just trying to get the techniques to work here.
Good.
So do you see my slides now?
Yes.
Great. All right. Well, thanks for inviting me, and obviously thanks to Laurent for the very nice presentation of the two RCTs, no, 2 out of 3 RCTs. And I will briefly basically go through the evidence in general terms, and more specifically try to focus on the consensus statement that we've sort of designed recently and published recently within the frames of the European collaboration, basically. So the main question is obviously, well, you have a patient for chronic subdural hematoma, you have interventional radiology, and can these help us treat our patients, right? Now I'm talking as a surgeon, obviously. So nothing to declare. And obviously, why is this important? Well, as you all know, chronic subdural hematoma incidence is rising, and chronic subdural hematoma evacuation is currently the most frequent neurosurgical procedure. This is also reflected by the number of publications out there. So you can see approximately from 2009 and onwards, suddenly this is the most interesting neurosurgical disease, right? And this is probably because the neurosurgeons sadly realized after the landmark study from Santorius and colleagues about the drains versus no drains, that this is actually a patient category where we can do randomized studies, right? Probably the only neurosurgical patient category when you can do so. And MMA has recently emerged as a new toy. And the question is obviously, is this a plausible alternative or possibly an adjunct to surgery, right? And I think this is also something that Laurent already showed. The sort of interest in this technique has rocketed the past couple of years, and also this is obviously reflected by the number of publications out there. Nevertheless, in the words of Lars Lexell, a fool with a tool is still a fool, and in order to not to be a fool, you need to know something about the technique and obviously the evidence to know how and when to use it, right? So the concept of MMAE has already been mentioned. I will just very briefly touch base upon that. I will go through the consensus statement that's been recently published, and I will also touch base about the RCT results, not in the detail that Laurent presented, but just give you some thoughts, at least my thoughts on these, okay? And finally, we'll obviously discuss where do we currently stand and what's the way forward. So the concept being, as Laurent mentioned, the leaky blood vessels, those are the ones that are supposed to propagate the sort of buildup of a chronic subdural hematoma. And those are obviously also the target of the embolization. Just to give you one example from my institution, because yes, we do use embolization here at Karolinska where I work. This would be a classical example, a 65-year-old male on antithrombotics due to a recent stent in the heart, right? So this is obviously a patient you really do not want to remove the antithrombotics on. He has right-sided hemisymptoms. He's been diagnosed as a bilateral chronic subdural hematoma, and you have CT control showing progression over time. So what do? Well, this was an example for bilateral embolization, and 4 weeks after, we were happy to see the result was a success. So in general terms, what are the pros and cons? And here I'm talking a little bit as a neurosurgeon, right? We like things simple. So what are the pros about this technique? Well, minimally invasive. Yes, it's said to be minimally invasive. Is it really? That's to be discussed, right? But at least the complications rate reported are somewhat low, somewhere between 2 to 5. The con, and obviously this is the main con of this technique, is the slow temporal effect. So what does that mean? Well, it means that if you treat a patient with embolization, you cannot expect the patient to have an effect of the treatment or any efficacy of the treatment within days or even weeks, right? You need several weeks for the treatment to sort of kick in and see the results on a CT scan, for instance. So this is something we need to be aware of, and obviously this prohibits the use of this technique as a single standalone technique in patients with large subdural hematomas with significant mass effect and neurological deficits, right? So this is something you need to have in the back of your mind. So in terms of the current evidence, so let's go back to 2023, right? Before the RCTs were published last year and before the consensus meeting and later on consensus statement that we drafted and published. So obviously retrospective data only. I think this is probably the largest meta-analysis that's out there, published by Artery and colleagues. And the main conclusion here was, well, the authors do recommend considering embolization in the chronic subdural hematoma management in general terms. Okay, but still, only retrospective data, right? So again, back in 2023, who was using embolization and who was not. And this is just to give you 2 examples of the extremes that were out there that also sort of led us to initiate this consensus statement. One extreme sort of viewpoint was the one from the UK. So NICE, probably many of you, or those of you that work in the UK are familiar with this institution. It's the National Institute for Health and Care Excellence, basically telling the UK physicians what can be used in terms of high-level evidence and what should not be used. And their conclusion back in 2023 was that embolization for chronic subdural hematoma should be used only in research. Okay. At the same time, the complete opposite in the US, this is the contemporary algorithm for chronic subdural hematoma management from the Barrow. Okay. So if you look at the flow chart and you look at the chronic subdural hematoma patients, unless the hematoma is so small that you should only observe the patient, in every other treatment tree, you add the embolization, right? So obviously these are 2 extreme opposites. And this was the fact that sort of also led us to realize, okay, maybe a consensus statement is a good idea. And before meeting for this consensus statement, we also looked through the abstract that in 2024 were presented from the 3 RCTs that are now published, as you all know. The 3 main studies are here, and Laurent already presented 2 of them. What's important, in my opinion, when you look at this, is that the EMBOLISE trial, the first one, okay, was powered for a separate group analysis, okay? Surgery versus surgery plus EMBO. Second group, conservative versus EMBO, okay? MAGIC MT, this is the Chinese trial, was powered for a combined group analysis. Okay, so you have 2 groups, surgery plus surgery versus EMBO, conservative versus EMBO. You then sort of add this group and you do a combined group analysis, conventional treatment versus conventional plus EMBO. And finally, STEM, again, a combined group analysis. You have surgery versus surgery plus EMBO. Second group, conservative treatment versus EMBO. You sort of add these 2 groups and you do a combined group analysis. So what back then in 2023, what did the abstract tell us? Well, this was the EMBOLISE trial. And as already been said, this part is so far not published. And back then it was still enrolling patients. So this is only the surgical cohort that we have data on. And back in 2024, in the abstract, it said that the endpoint to begin with was recurrence or progression leading to reoperation within 90 days. Okay, obviously, big difference, a significant difference. Okay, so preliminary results, positive. How about the MAGIC-MT trial? So this was the Chinese trial. And please remember here that this was a combined group analysis. Okay, so you have the conservative treatment, either best medical care, or you add on EMBO. Other arm, the surgical treatment, either you just do the straightforward surgical treatment or you add on EMBO. And again, these groups are combined to do the combined group analysis. Back then, the results were preliminarily positive with symptomatic recurrence or progression within 90 days in favor of embolization, obviously. And finally, this was the STEM trial. Again, you have two groups here and a combined group analysis, the non-surgical management with or without EMBO and the surgical management with and without EMBO. Again, the preliminary results, positive, highly positive, that is. But this is a little tricky endpoint, right? So here the author decided to have an endpoint that's either residual, a reaccumulation, a reoperation, or a severe adverse event within 180 days. And I find this very difficult to interpret, because how can you have a residual that might not affect the patient whatsoever and have it comparable to a severe adverse event such as death, right? So this is a little bit tricky to interpret, to be honest, in my opinion. So how about the group that sort of got together and designed this consensus statement? Well, as you can see here, there were several, obviously, radiological and interventional societies from the neurosurgical point of view. Or side, we have the EANS, but even the WFNS taking part of. And interestingly, we even have anesthesiology with us and the European Geriatric Society. Obviously, they're also important in managing these patients. And I can tell you it was not easy. Just as a side note on this, I can tell you that it was pretty clear that in many respects they sort of felt they were very positive to this technique, and in many ways they felt that we sometimes undertreated the patients. So we even had the discussion of whether or not neurosurgery should be bypassed in totally, and just that the geriatricians could send the patients for embolization and then back to the geriatric departments. So it was a hot discussion, I can tell you that. So we met in early 2024 in April. And just before sort of coining the statement itself, we had some definitions that we needed to set straight. So the first one being a chronic subdural hematoma needing intervention. So this is one that requires active management with either surgery or EMBO based on the patient's symptoms and radiological features, while a recurrent subdural hematoma is one needing renewed intervention. So again, surgery or EMBO, or both, right? This is what we sort of concluded based on the retrospective data I mentioned to you before and the preliminary abstracts from the 3 RCTs, that EMBO should be considered as a standalone treatment in de novo chronic subdural hematomas requiring intervention, but where surgery is prevented due to either coagulopathy or in those on antithrombotics in whom the risk of suspension is considered unacceptably high. Similarly, as a standalone treatment in recurrent cases, okay, where surgery is prevented due to, again, coagulopathy or in those on antithrombotics, in whom the risk of suspension is considered unacceptably high. And finally, as an adjunct to surgery in recurrent cases, mainly because if you have a second recurrence, the risk of a third recurrence is usually the double, right? So in these patients, you often tend to try to sort of do everything you can. This is the flow chart that we published as part of the paper. No news here compared to what I just mentioned to you. In de novo chronic subdural hematomas, when you decide that intervention is needed, you either go for surgery if patients are on antithrombotics that can be suspended, or you go for embolization if the other is sort of the fact. And in the recurrent cases, very similarly, if you decide an intervention is needed, if the patient is on antithrombotics where the risk of suspension is considerably unacceptably high, or coagulopathy preventing surgery, you go for EMBO. Other than that, you go for surgery plus EMBO. And we're pretty happy with this. But what happened 2 weeks later after we published our consensus? Well, the RCTs came out. So the main question now is obviously, can we still stand behind our consensus statement, or do we need to revise it? And just to give you some sort of my own thoughts on the matter. So after reading the RCTs, and again, 2 of them have already been mentioned. First one, the STEM, multi-center, convention versus embolization. Second one, the EMBOLISE, surgery versus surgeries plus EMBO. And finally, the Chinese study, conventional treatment versus EMBO. Primary outcomes, this one, again, very difficult to interpret, okay? 6-month residual hematoma, more than 10 millimeters, reoperation, major stroke, or death. This one having 3 months reoperation, solid endpoint. And the final one, the Chinese one, 3-month symptomatic recurrence or progression leading to reoperation. Again, in my opinion, quite solid endpoint. These 2, as already presented, the primary finding in terms of treatment failure or reoperation were significant, positive in favor of embolization. Nevertheless, interestingly, the Chinese trial, when they sort of redone the statistics, as you remember, the abstract presented was positive, but the final results of the study were actually negative, okay? And also, interestingly, if you look at the secondary findings, in my opinion, probably the most important one being MRS, right? The functional outcome, no difference between the groups in any 3 of these trials, okay? So it makes you wonder a little bit, okay, well, still, the majority of the findings were positive in favor of embolization. But something else that's quite tricky, in my opinion. Well, first of all, if you look at, and this is by no chance criticism of Lauren taking part of these trials, but anyway, if you read through the sort of the papers and look at the fine print, right? These 2 were sponsored by industry, and if you read the fine print in the articles, it actually does say company held all data, did the analysis, and wrote the paper. And the same was the fact for EMBOLISE, whereas the only one that was not financed by industry was also the one that was negative, and that was the Chinese trial. Okay, there was some missing data. This is to be expected in an RCT, but in the Chinese one, there was 0 missing data. Okay, this also makes you skeptic a little bit, right? How come they have a missing data? There were like 70 Chinese institutions taking part in it. In terms of the surgical treatment, as you all know, it's important that this is standardized. It also affects the result of a study like this hugely. In the STEM trial, there was no data on that presented. In the EMBOLISE trial and in the MAGIC MT trials, the subdural drainage, which are standard, and bowel surgery was also standard. So in sort of like when you're a surgeon, you like to get things served, at least in my opinion, easily. So it's easily understandable because there's a lot of data and a lot of different ways to interpret these trials, right? So you like to, the way I like to present this is like think on the numbers needed to treat. Okay, so how many patients do we save from a redo surgery if we apply embolization? And if you look through the numbers, in the STEM trial, it's 10. Okay, this is the surgical arm only, obviously. Again, you have to dig into the numbers, not significant. 10. Okay, so you need to embolize 10 patients to save 1 from reoperation, and the reoperation will not affect the MRS score. I showed you that. In the EMBOLISE trial, it's 14. And in the Chinese trial, it's 200. Okay, so you really need to sort of ask yourself the question, is it a reasonable treatment to add? And I'm not the right person to answer that question. That's obviously debatable. But I'm just saying these are some of the matters that I sort of had in my back in my head when I read through these trials. So the question is, the consensus trial, is it still valid? I can tell you, I don't know. I don't have the answer to that. We are planning an updated version of this later this year. So we'll probably meet again here during the spring, and hopefully we'll be able to publish a more updated variant. I can tell you that there are 24 RCTs ongoing, so hopefully in near time we will have more data on this. We have even a trial in Sweden called the SWIMA. It's, I think, a little bit more straightforward than many of the other trials out there. You have patients where the surgeon themselves, to begin with, basically decide whether or not patients are suitable to both be embolized or treated surgically. Okay, so you have a patient that are previously untreated. That's also important. And where with a chronic subdural hematoma, and embolization is one way to go, but an equally good way should be surgical evacuation. And these patients are then randomized on the follow-up, and the end result endpoint would be redo surgery, obviously. So in my opinion, the take-home message so far, at least, should be that, in my opinion, EMBO seems to have efficacy. I'm not saying it doesn't. We use it at our institution, and I definitely think there's a role for it. Is here to stay. Nevertheless, I would argue that the data so far is somewhat lacking, especially in terms of patient selection, the long-term outcome, and obviously the socio-economic aspects when I mentioned the numbers needed to treat, right, to at least from the 3 RCTs. And while we wait for the more randomized data from the RCTs that are ongoing to be published, at least something like a multidisciplinary consensus statement might guide the treatment practice. Thank you. I think I can help.
Thank you, Jiri, for this beautiful overview and presenting a consensus statement as well. Laurent, would you maybe first like to respond to the comments, Jiri?
I am not thinking that it's a competition between neurosurgeons and neuroradiologists. In my mind, it's just the best care we can offer to the patient. So I have just 2 comments regarding what Jiri said. One is a comment regarding the Chinese trial, which is MAGIC-MT. MAGIC-MT, they explained during the Shanghai meeting what is the reason for the change in the primary endpoint. Death was not included in the primary endpoint. So when you just evaluate the primary endpoint without death, effectively the study is negative. When you reincorporate all deaths or neurological deaths, the study is positive. By the way, New England Journal of Medicine refused to reintroduce death. Okay, I agree that methodologically it was acceptable, but let's say that if you re-include neurological death, the study is positive. One. Secondly, regarding the percentage of missing data in both Optimize and STEM, the reason is very simple. There are 2 most important reasons. One is we are dealing with very old patients that can die for another reason, which is not very surprising. And secondly, the studies were conducted during COVID-19 period. So it was, I know that because I was conducting a lot of studies dedicated to aneurysm or also other topics. It was a difficult period for all studies. So we know that from the beginning, and we know that it was difficult to collect data and to have the patient back for a lot of reasons you can imagine. So to me, it's it's a new tool that can be offered to the patient to prevent reoperation or recurrence of the subdural hematoma. That's it. So we have to use it when it's helpful for the patient, but we don't think that we will use this patient for all subdural hematoma, chronic subdural hematoma. That's completely clear.
Thank you, Laurent. There's several questions in the Q&A. Maybe, Laurent, the first one for you.
I completely agree with you, Laurent. It's as you said, and we had really good conversation and discussion on the consensus statement meeting already between ourselves as neurosurgeons and the neuroradiologists, and obviously we also had a lot of other societies there. So yeah, I agree. And good point with the MAGIC-MT trial and the missing data. Yeah, that's also why I found it difficult to understand that there were no missing data in the Chinese trial. So
yeah. But it's China. For that, it's China. But whatever. No, and maybe if I can add something, a very short point is, in my mind, the neurosurgeon is the first physician who is in contact with a patient with a chronic subdural hematoma, and he is the guy who is making the decision. In my department, why we started to do MMA embolization? Because neurosurgeon came to us. They say, we cannot manage all this chronic subdural hematoma with all this recurrence. Can you do something for us? It was their request, but in my mind, as of now, for the time being, the first line physician who has to manage chronic subdural hematoma is a neurosurgeon. And by the way, don't forget that both US trial, Adam Arthur, De Fiorella, Davis, they all are neurosurgeons. Don't forget that. So I am a neuroradiologist. I agree with Abeti because we are in Europe and it's a little bit different. But you know, they all are neurosurgeons, and don't forget that. But to me, it's completely clear. The first physician and the physician who has to make the decision at the beginning is the neurosurgeon for the time being, clearly.
There are many questions regarding the technical aspects, and I think the first one is for you, Laurent. Do you think that there's a difference between doing the embolization before or after the surgery? And from my personal point of view, how long do you think the interval should be between them?
No, but you know, I think Jerry gave us partially the answer to that. You know, MMA embolization is not a treatment which is directly efficacious, which means it's a preventive treatment somewhere in brackets. I agree, because it's not a simple treatment, but it's something you do to avoid an event in the future. So in my mind, you know, you can do it before and you can do it after, knowing that in my mind there is no benefit for the surgery to have it done before. So you can do, you know, for example, in I think in Optimize you can do it before and after. In STEM I think it was before, if my memory is good. For example, in EMPROTECT, which is a study which was conducted with in France with particles, and which is negative, by the way, but the treatment has to be done after the surgical treatment. So, but I think it makes no difference, honestly, because it's a preventive treatment for the future.
You also don't think that, like, the surgery can influence the penetration of your particles or your liquid embolics, because that's the rationale that some people say that that's the reason why you should do it before the surgery, but you don't believe personally that's true.
Yeah, but you know, I don't think there is a benefit for neurosurgery, singularly for a skilled neurosurgeon. You know, treating a subdural hematoma is not a very complicated operation. So I am not sure there is a benefit to do it preoperatively.
Yeah,
I heard that
you can do it preoperatively. I agree, but it's not mandatory.
I heard that the intervention team at our institution usually say that exactly as you say, Lauren, that there should be no difference. But if you are really unlucky as a surgeon and you damage the meningeal media in some way or one of the branches during the surgery, if you do the surgery first, then in theory, I don't know, but maybe the particles would have more difficulties, you know, reaching the territory where they're supposed to work. But again, I think this is mainly in theory.
Yeah. You know, that's the reason why maybe it will be interesting to have the subgroup analysis in optimized trial regarding distal and proximal embolization to see if there is a benefit. You know, it's still something which isn't clear, but it's a very technical point, let's say. But maybe in my mind, there is a benefit. You know, in my department, we try to always have a distal embolization. Even Adam Arthur was saying that sometimes, you know, by embolization only on one side, you can occlude MMA on both sides by having a reflux on the contralateral sides. Maybe there is a benefit of that. On probably there will be a study in France conducted by the team which was conducted on Protect. They will try to compare embolization on both sides versus embolization on one side. But okay, I am not sure. You know, but we are on Protect was conducted with particles, so you know, it's a different song somewhere.
And then related to that, somebody asked if there is a place for surgical coagulation of the MMA during burr-hole or craniotomy. Thierry, what do you think?
Sorry, I have to put the microphone. So I know that there is actually some at least there is literature on that. I'm not sure if there's literature on the clinical efficacy, but I'm sure that there is a literature on like the technical aspects of that you can sort of do that. I know there's the group from Copenhagen and Denmark published a study in ACTA where they used navigation, I believe, to sort of find the meningeal media and place the burr hole right on top of it and coagulate it. But the question is that enough? I mean, it does have branches, right? And it has collaterals as well. I'm not sure. I don't know if of any literature on the efficacy of it, but in purely technically, yes, it can be done. Yeah.
Thank you. And then there was also a question for the recurrent subdurals, where you want to do both surgery and embolization, whether you could recommend anything on the timing for the MMA in relation to the reduced surgery. So that's also touching upon the point we're just discussing.
Right. So the reason for us in the sort of consensus group recommending that for the recurrences you should add on embolization as standard to the surgery was mostly because of the high recurrence rate of like a second recurrence. So the first recurrence usually in modern literature is somewhere around 10%, right? In centers that have standardized techniques and so on. But if you have a recurrence, then the risk of a second recurrence is 20% at least. So it doubles. So in those patients, usually you will try to do what you can to prevent a second recurrence and to sort of time it, when to use it before or after surgery. We have that discussion right now at our institution because we are trying to standardize our protocols. Most likely we would go for embolization first and the redo surgery later, but still within the same admission. Okay, so we're not going to send patients away from the hospital. We just do it in the same admission.
Okay, great. And there were questions specifically for Laurent, if you could elaborate on the complications after MMA embolization, like how often they occur and what kind of complications those are.
You know, the risk of MMA embolization is one, anastomosis with, you know, ophthalmic artery and other difficult branches. I think in one study, there was a migration of, I don't remember if it's in OnProtect, maybe in OnProtect, there was a migration or in another study, I don't remember, but there was a migration of particles or liquid embolic agent in the M1 segment, and they have to do a mechanical thrombectomy. Finally, the clinical outcome was good. So that's the first complication you may have with MMA embolization. Normally, you know, you check everything to be sure singularly for the ophthalmic artery. And the second point is you can also have, you know, some connection between branches of the external artery with a risk of embolization in territory where you can have a risk of neurological complications. So that's a reason why that's probably a better option to do a distal embolization, because when you are distal in the MMA, you have no dangerous anastomosis and the risk of complication is low. When you do a proximal embolization with particles or even with onyx or any kind of squid, you know, you may have a reflux in a dangerous anastomosis and create a neurological complication. So that's the reason also why I personally, at the beginning of our experience in the department, I was a little bit reluctant to use liquid embolic agent, but you know, in fact, liquid embolic agent, you control better their progression than with particles. So you know exactly where it goes singularly because it's very radiopaque, so you see where it is. And if you're a reflux, you just stop injecting, and you wait, and you restart injecting after a few minutes, and so it goes again forward on in the right direction. So, but that's the main complication we may have in the MMA embolization.
And from a technical point of view, do you think that there's a role for a balloon catheter there, like a small balloon catheter? Do you say it's also suitable to do it with just a simple microcatheter?
Yeah, it's probably, you know, balloon catheter, micro balloon catheter, we use it singularly in brain AVMs, that's true, to control the flow. Here, we don't have to control the flow. And second point, you know, the flow is not the same in the external carotid artery and in the ICA. So probably is on third point is, you know, probably MMA branches are relatively small, and using a balloon in MMA branches, I don't see, you can probably do it, but I don't see too much the benefit of that, you know. So there is a question of balance of risk between the use of the balloon, the risk of rupture of the MMA, and the benefit of using it. I am not sure we have a benefit. We have a benefit when we treat brain EVMs, for sure, because we can control the progression of onyx or squid. For MMA embolization, I am not sure. It's more important in my mind, again, to navigate very distally with a mic than to use a balloon microcatheter.
Okay, thank you. Could you both elaborate on your protocols for interrupting the anticoagulants that patients use? Do you do that, and like for how long do you interrupt them?
Jerry, please.
Yeah, so if we, to be honest, we still don't have like a specific protocol at our department. We're working on it, but as you all know, and probably the person that asked this question also knows that very well, it's very difficult and there are no standardized sort of protocols available. If we have patients in general terms that go only for embolization, we don't post the antithrombotics. That's sort of the whole idea of it, right? If we operate on patients, it depends on the indication. For the antithrombotics, obviously, usually it's reinstated within 3 to 14 days. So 3 days, that will be obviously patients with important, not important indication, but a critical indication where it's critical to reinstate the antithrombotics quickly. Whereas like antithrombotics that are there for like secondary prevention in patients with hypertension, you can wait 2 weeks or even longer before reinstating these.
Globally, we do the same as you do. Let's say that we differentiate between the antiplatelet medications the patient are receiving. For us and for the neurosurgeon we work with, they consider that aspirin is not too much a problem. The problem is more potent antiplatelet medication like ticagrelor, prasugrel, blah, 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 blah. And they are more and more used by cardiologists and even by us. So I think in that case, you cannot continue this medication singularly when you have surgery. You have to stop them. But don't forget that, for example, if they have a relatively recent stent in the coronary stent or even in a stent in the brain, the risk is the thrombosis of the stent. So that's I think it's difficult to have a standardized protocol because it's really depending on each clinical situation, depending on when the stent was placed, etc., which medications they received. After a few weeks, it's possible to suspend the complex antiplatelet medication, the potent antiplatelet medication, sorry. But I think if for example you have a chronic subdural hematoma, few weeks after the placement of a coronary stent or intracoronary stent, I think it's a problem to stop it. So. But maybe don't forget that we have also what you say from the consensus. When patients are under antiplatelet medications that make it complicated to make surgery, maybe the first option is to do MMA embolization. Maybe when we can change the medication, if there is still a need for surgery, maybe at that time we can stop the medication and go for surgery if needed.
Exactly. And then finally, with the eye on the clock, can you elaborate on the costs of both procedures, including like hospital admissions, procedures, and the disposables that you use? Do you think that it's feasible with the number needed to treat and the extra costs that it's costing to make it socioeconomically valuable?
So the last figures that I know of in terms of how much does one embolization cost in terms of just material, it's around 2,500 US, right? So 2,000 euro or 2,500 euro, I think. I think this, obviously Lauren knows this much better than I do, but probably the costs differ a little bit depending where you work and what kind of the company. And I mean, if you do it in a single session or during the same admission, I don't think that the hospital costs in terms of admission or discharge differ much, besides the fact that you need to obviously use the anesthesia resources to get the patients to the hybrid suite or to the angio suite, and you need to sort of obviously encompass the costs of the material. But other than that, I don't think it's more than that. I don't know, Lauren, have you any sort of?
No, but I agree with you. Just one point, don't forget that the goal of MMA embolization is to avoid recurrence on the new surgery. So you have the balance is not only to analyze the cost of embolization, but also to analyze the potential cost of a retreatment. So it's a little bit complicated. So depending on the rate of re-intervention we avoid by MMA embolization, the cost will be beneficial or not for the patient. So that's a little bit tricky to analyze this point. Probably it's feasible, but we have to take it into account that MMA embolization, the goal is to avoid a new hospitalization, a new treatment, blah, 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 blah. So it reduces costs. So it costs something to reduce some costs. So it's a little bit.
Okay. As we're running out of time, I realized that we were not able to answer all the questions, but I want to thank Laurent and Jury for your excellent insights in the discussions, and everybody at home for participating. And I wish you all a pleasant evening. Bye.
Bye-bye. Thank you very much.